Hi everyone, and welcome back to the Central Ray Podcast ARRT Registry Review Series. I'm your host Ryan Ross, and today we are taking a deep dive into the thorax and the abdomen. This is three big sections of the content specifications that cover thorax, abdomen and GI studies, and also some GU studies. These areas are clinically common, but don't be fooled, they are packed with details the exams love to test you on, from positioning landmarks to pathologies and evaluation criteria. By the end of this episode, you will feel more confident in not only knowing what to do, but why. If you take a look at the 2022 content specifications, you can see there are 4 sections related to procedures covered by the exam. Those are positioning, anatomy, procedure adaptation, and evaluation. As we move into our discussion on procedures, that's how we will break down and review the material. So let's start our thorax review with positioning. One of the most important things to master in thoracic positioning, and really all positioning, is the use of topographic landmarks. These are surface anatomy markers that help us accurately align the central ray when the internal anatomy isn't directly visible. So let's discuss 2 key landmarks. First, we have the jugular notch, located at the superior border of the manubrium. This notch aligns with the level of T2 to T3. This landmark is especially helpful when performing AP chest radiographs, which are often done in the supine or seated positions for patients who can't stand. Since positioning an anteroposterior chest accurately can be a little more challenging, this landmark gives you a reliable reference to center the beam at the correct thoracic level. Paying attention to your beam angulation, the central ray will be located around 3 inches inferior to that jugular notch. Next, we have the inferior angle of the scapula. That is the lowest point of the scapula blade. This landmark lines up approximately with T7, which is the ideal level for the central ray in both the PA and the lateral chest projections. On a standing patient, this typically falls about 7 to 8 inches below the vertebral prominence, C7 for women, and about 8 to 9 inches for men. This reference ensures that the lungs are fully included from apex to base. The use of this landmark is more consistent than the commonly used pinky and thumb method. Accurate use of these landmarks ensures not only that your image is centered appropriately, but also that the critical anatomy like the lung bases and costophrenic angles are properly visualized. As we know, these can be vital in diagnosing conditions like pleural effusions or atelectasis. Routine body positions are erect PA and left lateral, which better demonstrate the lungs and reduce magnification of the heart. In the PA projection, the heart sits anterior in the chest and therefore appears less magnified than in an AP projection. This is also why we perform the left lateral, as it places the heart closer to the IR, reducing magnification and distortion. While 72 inches, or 6 feet, is the standard SID for chest radiography, especially the PA and the lateral projections, there are situations when a longer SID may be appropriate or even preferred. Some acceptable situations for using a longer SID would be mobile radiography with limited room to get close. When performing portable chest x-rays in an ICU or surgical setting, sometimes the x-ray tube must be positioned farther from the patient due to equipment, bed rails, or infection precautions. If you talk to anyone back in the COVID days, we would be routinely shooting larger SIDs due to the infection controls. In these cases, if the SID ends up being longer than say 84 inches or more, that is acceptable as long as you compensate for the increased distance by adjusting your exposure, typically increasing your MAS to maintain image receptor exposure based off of the inverse square law. Also remember to adjust your collimation. 2. Dedicated long SID rooms, such as those found in trauma or dual energy chest units. Some high-volume trauma rooms or specialised chest imaging rooms are designed with fixed SIDs longer than 72 inches to further reduce magnification and improve spatial resolution of the heart and mediastinum. A 96-inch SID is occasionally used in these dedicated systems to achieve the sharpest possible image with minimal geometric distortion. But remember, any deviation from the standard 72 SID must be documented and justified if it affects the technique charts or standard protocols. Most importantly, always adjust your exposure to compensate for increased or decreased distances as the beam intensity falls off or increases based on this change in your SID. So yes, while 72 inches is standard for chest, you absolutely can use longer distances when clinical conditions, equipment design, or technical preference support it. Just make sure your image quality and exposure remain optimal. Breathing instructions matter. Deep inspiration, we really want 2 relaxed inspirations to fully inflate those lungs. Failure to fully inflate the lungs may misrepresent anatomy due to the relevant volume of the heart appearing larger relative to the full capacity of the lungs. Now, if you're looking for a pneumothorax though, what kind of respiration might you use? If you said at the end of expiration, go grab yourself a piece of candy, you are correct. I have worked in facilities where this was not the case, but do not let that distract you if your protocols that you see don't ask for expiration. That is what the textbook says, and that is what you will be expected to answer on a registry exam. So let's talk about the anatomy. The thorax includes the lungs, heart, bony thorax, mediastinum, and associated structures. Understanding the basic physiology is also important. For example, knowing that the right lung has 3 lobes while the left has 2 and a cardiac notch. You'll also need to recognize common pathologies on chest radiographs, such as pneumonia with those consolidated lung markings, atelectasis with the loss of lung volume, the shift of structures towards the affected side, cardiomegaly as a result of CHF, congestive heart failure, and then a key one would be pneumothorax, looking for the absence of lung markings and for a clearly visible pleural line. Then talking about some procedure adaptations. Not everyone can stand upright for a PA lateral chest. For trauma or limited mobility, you may have to perform an AP supine chest or seated, but be aware of the limitations and, more importantly, the consequences, such as increased heart magnification and the possibility of poor lung aeration. Portable cross-table laterals are sometimes needed in ICU patients that are unable to sit in an upright position. For patients with larger body habitus, centering slightly higher and increasing exposure factors can help penetrate mediastinal and diaphragmatic regions. Lastly, a few words about image evaluation. When you're critiquing a chest radiograph, here is what you're looking for. Proper inspiration, at least 10 posterior ribs visible above the diaphragm. No rotation. We are looking for equal distance between the SC joints and the spinous processes. That both scapulae are out of the lung fields. There is no motion blur. And that we have proper penetration and that lung markings are visible throughout. For the lateral, look for superimposed posterior ribs, or even better, superimposed costophrenic angles, open vertebral spaces, and no tilt. Moving on to the abdomen, the 2 routine projections being tested are the AP supine, commonly referred to as the KUB for kidneys, ureter and bladder, and then the AP upright. For a KUB, we look to center to the iliac crests, ensuring the symphysis pubis is included. For an upright, we center 2 inches above the iliac crest to include the diaphragm. The breathing instruction require exposure taken at the end of expiration to avoid diaphragmatic movement and also to ensure the organs are at rest. Topographic landmarks of concern for the abdominal region are the xiphoid tip around the T9 to T10 region, the iliac crest, which represents L4, L5, and the ASIS. The SID is typically 40 inches. When we talk about fluoroscopic GI studies, we are looking at a more dynamic form of imaging. Unlike routine radiographs, these procedures allow us to visualize real-time function. Things like swallowing, peristalsis, reflux, and motility. It is essential to know not only the anatomy and the contrast used, but also the typical projections and their corresponding centering points. Let's walk through some of the most common studies and highlight what you need to know for the registry and clinical practice. We will start with the esophagram, also known as the barium swallow. This study is focused on the pharynx and the esophagus and is especially helpful for evaluating swallowing function, strictures, or possible varices. One of the most useful projections here is the RAO, angled about 35 to 40 degrees. This position separates the esophagus from the spine and the heart, making it easier to evaluate the esophageal wall. The lateral view provides excellent detail, especially in the cervical region, while the AP or PA view shows the esophagus overlying the vertebral column. For all of these views, the central ray is typically directed to the level of T5, T6, which places you about 2 to 3 inches below the jugular notch. Next up is the upper GI series, which extends from the esophagus through to the stomach and into the duodenum. This study is all about watching the movement of the barium through the GI tract and observing structural abnormalities such as ulcers, hiatal hernias, or tumours. A variety of positions are used here, each designed to highlight different parts of the stomach and the duodenum. The RAO is perhaps the most important. It opens up the duodenal bulb and the pyloric canal, giving us the clearest view of those areas. The right lateral is especially helpful for showing the retrogastric space, while the LPO fills the gastric fundus with barium. Supine and prone images are also used to vary the distribution of air and contrast throughout the stomach. Centering depends on body habitus. For average or sthenic patients, the central ray should be directed to the level of L1 or L2. Hypersthenic patients require a higher and more lateral centering point, while asthenic patients typically require a lower and more midline approach. Following the upper GI, a small bowel follow-through might be performed to trace the passage of contrast through the jejunum and the ileum. These studies are done using timed AP or PA images, usually taken every 15 to 30 minutes, but this can vary depending on department protocol, until the barium reaches the ileocecal valve. Early images are centered about 2 inches above the iliac crest to include the stomach, and later images are centered directly at the iliac crest around the L4 to L5 region. Now let's talk about the barium enema, which is used to evaluate the large intestine. This can be done as a single contrast or double contrast study depending on the clinical question. Routine projections include AP or PA views of the abdomen to show the entire colon. Obliques are extremely valuable. RAO best demonstrates the right colic's hepatic flexure, while LAO opens up the left colic or splenic flexure. You'll also often use LPO and RPO, which are functionally the same but reversed. The left lateral rectum projection is ideal for visualizing the rectosigmoid region, and an AP or PA axial with a 30 to 40 degree tube angle is often added to open up the same area without superimposition. If the patient can't stand, a left lateral decubitus is typically used in double contrast studies to highlight mucosal patterns and detect small polyps or air fluid levels. Centering for most of the colon is done at the level of the iliac crest, but for the flexure views, you'll want to slide slightly lateral, about 1 to 2 inches towards the elevated side. Throughout all of these fluoroscopic procedures, spot imaging is used to capture critical structures in high detail during live motion. Compression paddles, breathing instructions, and patient rotation all play important roles in enhancing the visualization of the anatomy. And remember, knowing the distribution of air and contrast in each position helps you predict how different pathologies will appear. In upper GI studies, for instance, air tends to rise and barium settles, so prone and supine can drastically change how things look. Finally, contrast type matters too. Single contrast studies use barium alone, while double contrast studies incorporate air to better highlight mucosal patterns and detect fine lesions. Understanding the contrast flow, the patient positioning, and the timing of your exposures is what makes you not just a good technologist, but a great one. Let's discuss the abdominal anatomy. Key structures you'll need to identify include the liver, kidneys, stomach, small and large intestines, the psoas muscles, and diaphragm. Pathologies often assessed with abdominal imaging include ileus, or paralytic or mechanical. It's gas patterns and air fluid levels. Ascites is a diffuse haziness. Perforation would cause free air under the diaphragm on upright or left lateral decubitus. And then obstructions would represent dilated bowel loops and air fluid levels. For GI studies, understanding motility disorders, reflux, ulcers, and diverticulosis is essential. Some procedural adaptations. Trauma patients may require decubitus views rather than upright to assess air fluid levels if they cannot stand. For pediatric or geriatric patients, adjusting exposure factors and consider shielding carefully. Obviously, there's been new guidelines on shielding. For patients with a larger BMI, you may need to use higher KVP and grid techniques to penetrate adequately. Although this will increase scatter, hence the grid cleanup, but these can be challenging regardless of any techniques that you use. And then talking about image evaluation, for a KUB, make sure the symphysis pubicis is included with no rotation, sharp image detail and appropriate exposures to see the soft tissue structures. For the upright, make sure the diaphragm is entirely visualized. For GI studies, assess filling and coating of the mucosa, motility patterns, and clear demonstration of abnormalities. Finally, let's talk about genitourinary studies, including IVUs or intravenous urograms, retrograde pyelograms, cystography, and voiding cystourethropy, or VCUG. For an IVU, you'll take a series of timed images, usually starting with a scout KUB. Centering is similar to the abdomen at the iliac crests, but adjusted as needed for kidneys and bladder. For a cystogram, the bladder is centered 2 inches above the symphysis pubis. VCUG includes oblique and AP images during voiding. Oblique images or oblique views are often used to demonstrate the ureters free of spinal superimposition. The anatomy of interest, you will need to be able to recognize the kidneys, ureters, bladder, and the urethra. Remember, the kidneys lie around the T12 to L3 region, with the right slightly lower due to the liver. Common pathologies you will image include hydronephrosis, calculi or kidney stones, reflux, and bladder rupture or diverticula. Some procedural adaptations. Be ready to adapt for patients with reduced renal function. Contrast media may need to be adjusted or non-contrast studies considered. Pediatric patients undergoing VCUG may require immobilization and camming techniques. Shielding the gonads, if not obstructing the anatomy of relevance. For trauma, CT may replace IVU studies, but in a registry setting, you still need to know the classic techniques. And then image evaluation. On a proper IVU series, the kidneys, ureters, and bladder should all be visualized with the appropriate contrast filling and no motion. On cystography and VCUG, check for bladder wall contour, filling defects, and urethral patency during voiding. Alright, so let's wrap this up. Today we have reviewed the thorax, abdomen and GI, and GU studies for the ARRT exam. We cover positioning landmarks, standard projections, anatomy, pathologies, and what to look for on your images to evaluate quality. We also talked about adapting techniques for different patient needs, a skill that shows you're not just technically competent, but also clinically aware. So to end, let's ask a couple of review questions. So on a PA chest x-ray, how can you assess for rotation and adequate inspiration? Question number 2. What are the key differences in positioning between an upright and a supine abdomen? And then 3. Why is it important to use oblique positions during a cystogram or an IVU? So take a moment to reflect on those and quiz yourself later to see how much you've retained. I will give you the answers to these questions on the next episode, so please remember to subscribe and hit that bell notification if you're watching this on YouTube, and I'll see you on the next one for that. So again, thank you for spending your time with me today. Keep studying, reach out with any questions, and remember, every image you take is a chance to make a difference for your patient and your team. I'll see you in the next episode where we'll tackle even more of the ARRT content. Until then, stay sharp and happy imaging.